we are here today to talk about the emergency response codes. Again, this will be a bit of an experiment, so we'll see how it goes, but the emergency response codes, as you know, are exclusively used by healthcare systems across Canada. You know them, you love them, maybe you hate them, and maybe you've accepted them as a fact of life in healthcare disaster management, but I hope to convince you today that there is a better way. And to do that, I'm going to touch briefly on where they came from, why we use them, what they've actually become compared to their intended use, and then I'll present an argument as to why I think it's time to decode our plans and resources. Then Shannon, the real expert here, will take the stage and chat about how our organization made the switch to plain language, and she'll take some questions while I crunch the data and come back with the survey results. I'm particularly interested in connecting with anyone who's currently undertaking the transition to plain language within Canada, so please share your story during the Q&A or reach out to either of us directly. So where did they come from? Well, once upon a time in the 1960s, somebody came up with code blue, and that was kind of the original emergency response code, and it continues to be the most consistently used code across at least North America. There are also a number of other reasons why codes stuck around. One of them were different focusing events. The one that I picked out as an example for this presentation comes from the States at the West Anaheim Medical Center in 1999 on September 14th. An active shooter and an aggressive patient initially, but then became an active shooter, entered the hospital, and they decided that they were going to call a code gray. In their hospital system, that was the code for an aggressive patient. And this alert drew staff members towards the shooter and resulted in 3 staff members dying who probably wouldn't have died if plain language was used or if a different alert had been made. The result of this incident triggered a bit of a review of processes within the hospitals, and they decided that rather than kind of reviewing the code process, they're going to double down and make sure that all of the codes were standardized. Something similar happened in Canada. We're all probably pretty familiar with the Ontario Hospital Association standardized emergency response codes. If you're not, somewhere around 1993, a group of 13 people got together, decided that codes were the way to go, and their rationale was they wanted to reduce the chance of human error and eliminate confusion. And we'll revisit that throughout the presentation, but I actually think the opposite has happened when it comes to emergency response codes. This decision was reviewed in 2006, and they found that despite the standardization, hospital organizations across the country and in Ontario were not adhering to any particular standard. They were creating different codes and coming up with their own ways of doing things. And they came again to the conclusion that really this meant that we had to re-standardize and re-up the adherence portion and not change the way we're doing things. And a fun fact with the OHA standards, code gray does not actually have a standardized meaning, and we'll get more into that. So looking at the intent of the plans and the codes, originally the intent of the codes was to rapidly communicate with staff the need for a specific response. And I think this is actually a really good definition and intent of the codes. You know, codes mean one thing to a predetermined group of people for a predetermined response. Rapid communication, singular meaning, I think we're good to go. As you can see with some of the other definitions, it's begun to kind of merge into some different things. So this second one here says to convey essential information. And one of the issues here is that codes don't actually convey information. They just convey a singular meaning. Information is based on the hazard or the incident that's occurring. And to appropriate staff, not sure who appropriate staff might be. And then this is the one I really have issue with. While minimizing stress and preventing panic amongst patients and visitors, this really reinforces a disaster myth that mass panic is caused by public alerting and having information, where the opposite is actually true. Lack of information or poor communication causes a lot of stress amongst people. The last one comes from Quebec, and it's to identify something, but from context, I think they were talking about the hazard, and notify the most appropriate individuals in an event that requires an immediate response. And here I think we see where codes started to merge into meaning a specific response, into meaning some type of specific hazard. So starting to talk about the hazard instead of the desired result. My apologies, I just have to plug in here. My device is pinging at me. Perfect. So what have the codes become? Well, I think they have become confusing, numerous, and non-standardized. There are lots of examples of people having code confusion or calling the wrong code and initiating the wrong response in reaction to complex or poorly defined hazards. There are more codes and color codes and numeric codes and code words than you can shake a stick at. And even within provinces and across Canada, they are no longer standardized. For example, Code Gray in BC means system failure. In Alberta, it means shelter in place or air exclusion. In Ontario, it can either mean infrastructure loss or external air exclusion. And in Quebec, it doesn't mean anything because they don't have a code gray. Code purple can either mean bomb threat, hostage taking, or neonatal cardiac arrest, depending on where you are. And code red, which you think maybe is the most obvious one and means fire, gets confused often with other partner agencies' version of code red or red alert. A good example comes from an incident in Calgary recently where there was a truck crash at a warehouse, and in the communications for the incident management team, EMS said that they were basically in a code red. That got translated as a code red fire, and hospitals began preparing for mass casualty burns, which was not what was going on. I also think that the codes are a poor substitute for a robust hazard, risk, and vulnerability assessment. You know, having codes as the framework for all of our emergency response plans means that we're only planning for 12 things where hundreds of thousands could happen and intersectionality could also happen. They're also a barrier to effective public alerting. By their very nature, they're exclusionary, non-descriptive, and only mean one thing, and they do not effectively alert all of the stakeholders. And they don't really align with the all hazards planning either. You cannot fit complex emergencies into boxes. And as I think we've demonstrated with the speakers today, disasters happen in clusters and they intersect and they impact each other. You know, a flood can turn into an infrastructure damage, can turn into a power outage very, very easily, and that can cause some code confusion. So my question is it time to decode emergencies in Canada? And my argument for you is, be it resolved that emergency response codes do not work in practice, are not evidence-based, do not reflect best practice, detract from a successful response, are not effective alerting tools, are not equitable or ethical to use, and need to be retired now. And I hope to convince you of that in the next 5 or 6 minutes. So let's go over a few scenarios to show where codes are failing in the real world. So scenario one, you might remember this. This was out of the news. There were swatting calls, the threats of armed gunmen appearing at different children's hospitals across Canada on the same nights. Thank goodness it was a hoax. But my question for you is, what code is this? It's not an active assailant because there's nobody there. It's not a bomb threat because it's not a bomb threat. What is it? If you asked these different hospitals, they all came up with different answers. Some called code white, some called lockdowns, which is not a code, but is a very effective action for many different scenarios. And then some called code black. So very different responses across hospitals for this very same incident. And they were focused mainly on what code to call and not what to do. If you took aside any protective services member at a hospital and said, there are armed gunmen coming, what are you gonna do? They're gonna say, I need to lock down immediately. And that's the sort of thinking we need to encourage, not trying to identify an unknown hazard and match it to a random code. Another example comes from Calgary again. Car crashes into a healthcare facility, and this has happened many times before. What code is that? Is it intentional? Is it unintentional? Is there a bomb in there? Did it cause a fire? Did it cause air quality concerns? Is it a mass casualty incident? It's all of these things all at the same time, and you run that same risk of wondering what it is as opposed to what you should do. One more example, and then we'll move on. Here's a scenario of someone outside with a fake gun. And again, what code is this? They're not actively causing harm. We don't even know if it's a real hazard. And then as part of the response, there was tear gas used. And what eventually occurred, I think because of the tear gas, is they call it a code gray, which in Calgary means air quality issue, which meant that everyone went to the windows, closed them, and then stayed just inside that area. So right next to the hazard area, which is, you know, luckily it was nothing, but that's not the response we wanted to elicit there. So if there are problems with the codes, then where's the evidence for them? And the answer is there isn't any. It's not very well researched in terms of concrete evidence, trials and comparisons. But on the other side, to be fair, there's not a ton of evidence for plain language use in hospitals either, because I think it's probably too new. Asper Tracy completed a literature review on this subject, which I'm going to just drop into the chat box here, and I think it's a good resource, and you can start taking a look at that. And there is a lot of support for plain language alerting in general in emergency management. All of the alerting systems are moving towards plain language. And there are a few articles and opinion statements, I'd call them, in support of codes, but the pattern that I saw with these research articles was that they successfully identified issues with the codes, their reception, understanding, errors in practice, standardization, all that sort of stuff. But then they made a massive leap of logic, in my opinion, and decided that instead of examining the tool, we just needed to try harder and standardize more and enforce more, instead of recognizing that what we've been attempting to do and failing at for the last 50 years has to do with the tools, not how hard we're trying. So I found a couple of articles that I think are kind of worth going over. This one is Hospitals Should Replace Emergency Codes with Plain Language by the person, Dukowitz, sorry. But the basic argument he makes is that emergency response codes basically segregate staff from the public and reduced information regarding the threat, or gave different information to different people about the same threat. And then his thesis statement was plain language improves coordination between response partners. So getting that interagency look, I think, is very important. He also found that there are significant variations in meaning and understandings of codes. This was a US article, so federal agencies in the US are calling for plain language codes, and almost every other organization has jumped on that bandwagon while hospitals lag behind. And that codes do not recognize that intersectionality of hazards. There's a really, really powerful example that he used in this particular article, and this comes from the Bronx Lebanon Hospital Center. Again, there was a shooting, which some people might call code silver, but staff recognized this dangerous situation when a code silver was announced, or at least some of them did, and some of them took actions to protect their patients and themselves, which was good. However, in this situation, multiple emergency response codes, including code red, because of the smoke, code silver, because of the active assailant, and code 99, which I don't even know what that is, were announced to address the simultaneous smoke conditions, shooting, and medical emergencies, respectively, which resulted in some confusion and triggered different responses than what was intended. This one is plain language emergency alert codes, the importance of direct impact statements on hospital emergency alerts. And again, they recognize the variation in codes, which leads to staff confusion, and the use of codes decrease the amount of transparency projected to its patients and visitors. And then they did a bit of an opinion poll, and according to them, an overwhelming majority of healthcare professionals would prefer to use plain language. And I think these two articles really just show that there is, at the core, a fundamental disagreement between whether or not we trust people to make decisions and be flexible during disaster, or take that decision away and rely on systems and standards. And in my experience, disasters just haven't read the standards, so can't be put into boxes. So, if there's no real evidence, solid evidence or trials out there in either direction, that means that we have to turn to the same thing we always do in emergency management, and that is this idea of best practice. And I really want to stress that there is a difference here between common practice, which is what we're doing now because we all did environmental scans and copied each other until we created a nationwide echo chamber, and best practice, which is usually guided by some degree of evidence or at least expert consensus and advice. And in that realm, we have a lot of support for plain language. The USDH, SFEMA, DDHS, IFCA, that's right, the biggest propagators of technical terminology and acronyms have all advocated publicly in writing for plain language during emergencies, particularly FEMA, which states that it's important for responders and incident managers to use common terminology and plain language in emergency response as a matter of public safety. And the International Fire Chiefs Association has released a consensus statement to transition even first responder radio communications to plain language because they recognize that codes limited interagency coordination. If you need something a little bit more hospital related, there are many guides and implementation toolkits and consensus statements in hospitals in the States, as they seem to be well on their way to transitioning to plain language. One of the most powerful kind of statements that I found coming out of the Champaign Regional Healthcare Coalition is for the safety of patients, visitors, and staff, healthcare organizations must begin the process of transitioning from the use of code words to announce an emergency to the use of plain language. The use of plain language will lessen confusion and will give notification of a crisis. Notification may give innocent persons an opportunity to seek a more safe location. And that really brings me to what I think is the most powerful argument here, which is this equity and ethical argument. And in Canada, we have the right to know. If you're in a building, you have the right to know if your life is in danger, if a hazard is about to impact you. And this quasi-constitutional right must be safeguarded as a fundamental pillar of our democracy, even in the midst of a crisis. And that is a direct quote from the Information Commissioner of Canada. So at a very high level, we do have the right to know. I also have noticed over the last couple of years a number of news articles and increased attention when it comes to public alerting, use of plain language, the quality and timeliness of alerting. We can all probably remember the debate over the alerts during the atmospheric river events in BC, all the problems with the COVID alerts, and then still under investigation, and probably the most important one, I think, to do with alerting is the Nova Scotia mass shooting, where the public alert, which could have saved lives, was actually restricted, according to testimony so far, because they didn't want to cause a panic. And they only got the alert out about 5 minutes before the incident was concluded. So it really is in the news, and definitely not an ethics expert, but one of the easiest things to do for ethics and morals is a headline test. So here's your headline test. 12 dead at local hospital. Hospital employees knew about the shooter, said nothing. It makes me sick to think that this might show up any day in our healthcare system. And the only thing that I can think of that would be worse is if our codes were complicit in causing harm, or were called wrong and actually drew people and caused additional harm. So my conclusion, looking at both the best practice, some of the practical implications, and the available evidence, is that withholding critical public safety information through use of emergency response codes is inequitable, unethical, and may soon have legal consequences. So I think that's something we all need to think about as we come out of COVID and kind of reevaluate what we're doing. So as a quick summary, I think that there are actually appropriate uses for codes, even in healthcare, but they're very specific. And in healthcare systems, I think that codes could be appropriate when communicating response requests privately between affiliated and trained responders in situations that do not imminently impact public safety and where the same result cannot reasonably be achieved through the use of plain language. So the one that stands out for me is what I would call Code White, which is a secret call for help to de-escalate a potentially violent situation. The violence hasn't happened yet. And I find that quite useful. A lot of people have little duress alarms or little code words to talk to each other to say, hey, can you just come help me for a moment? That doesn't have an imminent impact on public safety. And it's a reasonable expectation that, saying that in plain language might actually aggravate what's going on. So I think there are cases, use cases for codes, but there's a lot of inappropriate use cases for codes, such as communicating a hazard or emergency information through public alerting, emergency notifications. I also think it's not appropriate to use codes as a kind of axis for our planning activities. We shouldn't be planning for a code red, because a code red is just a term. It's just a word. It's just a code. We should be planning for infrastructure damage in general, whether it be fire, flood, whatever. Response level activations, I get a little bit nervous when I see response levels attached to different codes, because I could imagine a small spill becoming quite major depending on where it actually is. Educational products, we should be educating on resilience and preparedness, not a system. And then the one that I'm really nervous about is amplification through technology. If we start using technology and increasing our program effectiveness, it's just going to amplify what we're putting in. And if we have garbage in, we're just going to get more garbage out. So I really don't think there's many use cases for codes, and I'm quite nervous about continuing to use them in healthcare. So if all of that is true, and maybe that's a big if, what do we do about it? I think now is the right time to change. One of the reasons I think that is it's already proven. You know, in the US, implementation work is already done. There are a number of implementation guidelines, and we don't have to be pioneers in North America. We just have to be pioneers in Canada. Someone's got to go first, and to be honest, I think it probably has to be Ontario because we generally follow suit from there. I also think it's the right time because our programs are generally in disrepair right now. You know, I think everyone on this call would agree that the focus on COVID response has set us back quite a bit. And just as development programs in global South countries have elected to simply skip antiquated infrastructure such as landlines and focus on cell towers, we can either choose to double down once again and add another coat of paint to the code system and commit to another 50 years of status quo, or tear it down, build something better for the long term. So my stance is Viva la Revolution and all of that. A couple of arguments against making the switch. The ones that come up are that we don't want to cause a panic argument. And again, panic is largely a disaster myth. There's the sunk cost argument. You know, we've always done it this way. We spend a lot of money on the products. We've implemented it. Everyone's trained this way. Yeah, it's going to be expensive to make the change, but the cost of not changing is much, much higher. Not could be or will be, it is much higher. And it's measured in injuries and trauma for our staff, poor outcomes for our patients, and loss of trust in our institutions. So the question we arrive at is, if not codes, then what? And for that, I will hand it over to Shannon Saunders to answer all of your questions while I crunch the numbers.
Awesome, thank you. And Grayson, do you have my slide? Just one more slide. There we go. So hi, everybody. And Grayson set this up for me perfectly. So I'm going to go a little bit in reverse, and I'm going to talk about what happened when I arrived at the hospital. And then I'm going to talk about how we got to where we were. So my orientation, well, I didn't get orientation because I arrived in New York City on April 1st, 2020, and April 7th was the height of our COVID response. So there was no time to orient me. There was no time to orient the thousands of travelers, volunteers, disaster credentialed personnel, and other people that showed up at the hospital to help when we were the epicenter of COVID. So my perspective is really one of, this is how it works, and it's amazing. I was given this card. This card replaced our badge. This card is called a badge buddy, and it replaced our decoder cards that we would have had at the hospital previous. And one side of the card is very specific about fire, and fire is the only code color that we still use, and that's only because in New York State, the fire marshal, they don't call it a fire marshal here, but their version of the fire marshal insists that we continue using the code red. So we slip the word into our plain language. We still use all of the plain language pieces, but that is the only color that we use. And again, it's secondary, and it's only because it's a legal requirement. It's not because we want to do it. And then the other side of the card really shows this is what you're going to hear. So we have 3 different types of codes because they have 3 different generic types of responses. So security alerts would be anything that involves security taking the lead in the response. Facility alerts would be anything that involves our infrastructure, and medical alert is anything clinical. When I arrived at the hospital, I was given the card. I was told, you will absolutely understand the plain language. And if something comes overhead, just listen for the instructions and you'll know what to do. And really it follows that idea of, you know, when the television cuts out and they say, this is an emergency announcement, here is what's happening and here's what you need to do about it. It very much follows best practices for emergency mass notification, and it allows us to notify everybody all at the same time. Sometimes we will get instructions, sometimes we will not get instructions. So my rapid response team that responds to our cardiac arrests on campus, I don't need to tell them as part of the medical alert to respond this way. I just need to say medical alert, rapid response, Babcock building, unit 4 west, room 121. And they know where to go and what to do. If it is something that requires a little bit more information, we can add instruction to that. So for example, if we had a facility alert flood, Babcock building, unit 4 west, please avoid the area. So my engineering department knows if there's an overhead page for a flood, they're on. They're to go and respond. I don't need to give them instruction, but to give the rest of the hospital instruction that this may now be a restricted area and to please avoid the area if you can. And that's a very simplistic answer. So I do want to talk to you a little bit about how we get there. And it's all the brainchild of Ben Derkowitz. So Ben worked for Mount Sinai Health System. And in 2018, as part of his master's degree program, he published an article on that Grayson was talking about. He published an article on the movement towards plain language. There were some hospitals in the area that were considering it. There were other hospitals in the country that were doing it. And there was a lot of conversation like the one that we're having now. Do we want to work towards re-standardizing the colors? Because it's so easy as people start to recognize new issues. We got to add new colors. We're almost out of colors. If you have, we're into teals now, which, there's only so many colors in the Crayola box before we have to start playing around with shades. And I'm not looking forward to the day where we have to have an overhead page that says code chartreuse, right? Because I don't even know what that is. I'm going to be honest. So we worked pretty hard to create it, and this is what happened. So this was a working group committee. They spent a great amount of time between security, emergency management, health and safety, and our telecommunications department. And they actually went through and created some generic and then some specific templates for telecom to use. So when I'm the nurse manager and I call our emergency number and I say, hey, I got an emergency here, here's what's going on, they can pull up the appropriate template and they know exactly what to read. Or they know to ask the question for some of the alerts, do you have any further information people need? Or what is the next step you want people to take? Which really allows us to put this piece in place really quickly and easily. So they created templates, which just made it easy. Our telecommunicators, I love them. They're some of the most important people in the hospital, but it's not a very highly skilled job. So we needed to provide them with the tools in order to feel comfortable doing this role. And I think in the past 3 years, we've really done that. And we've been able to expand on it. Plus, they have to get beyond the nurse manager, trying to tell them it's a code pink, it's a code pink, it's a code pink. And they're saying, yeah, we need a little bit more information. So we gave them the tools to do that. And they created some templates. This went along with creating templates for our other mass notification. So now we can put our security alert for an armed intruder, and I'll give you an example of that in a second. We put our security alert for an armed intruder that goes on the overhead. Once it's through the overhead, we can follow that same information, or as it's going through the overhead, we follow that same information to put it out through our mass notification system. So it's coming to people's phones and emails and however else they're getting the information. So it allows us to tie in that technology that I just don't think the color codes allow us to do. Or there's a million extra steps that now we have to collect the extra information because the color codes don't inherently have that information. And I can literally call telecom about anything. And as long as I can tell them it's a security alert, a facility alert, or a medical alert, we're able to put together those things. The other thing it does, my hazard vulnerability assessment, we use the Kaiser Permanente tool. Well, we use a modified version. The original version, I think, has somewhere in the neighborhood of 56 or 58 hazards. We can create templates for all of those hazards. So anything that could show up on my hazard vulnerability assessment, now I have a code for, or I have a way of communicating without the necessity of having to decode something. And then I have the opportunity to add or delete. So our modified template for our HVA actually only has 46 because we've combined a few. So we have 46 hazards, we have 46 templates. And I can grow from there. If something happens that's outside of what we would normally call a hazard, I can still use this process to be able to put this novel piece out. So it really, I think it works really well. So once we had the templates, there was a little bit of marketing to go with that. And the marketing was we created these badge buddies. So we replaced the old badge buddies with new badge buddies. That was a good thing to do in the moment as we were creating it. Now that this process is 3 or 4, actually 5 years old, now that this process is 5 years old, we don't really need these cards. Like I don't need to explain the difference in writing, the difference between a security alert or a facility alert. Because of the plain language, it's communicated well enough that there's really no training involved. But during the conversion, we did a huge PR campaign. Everybody got one of these cards. We created posters that went up in the units, in the break rooms, in the support service areas. And because we're a lean hospital, we have daily management boards. It went up on all the daily management boards so that we could piece those pieces together. And then we put little cards beside everybody's phones so that we could, so that when they picked up the phone, they were reminded not to worry about the color, just tell us what's happening and we could go further. And then we brought coaches in to work with the telecom so that there was extra bodies to help reconnect some of these pieces. So it was a little bit labor intensive to do the changeover, but now, like I said, I walked into a disaster, as did thousands of other people in my hospital that were volunteers, that were disaster credentialing, that were new graduates. We don't have time to train people, and there was zero need to train people in plain language. Really, all we had to say was, we don't use color codes here, we use plain language. You're going to understand what happens. And somebody asked a little bit earlier on during Grayson's presentation, being in New York City, English is almost a second language here, especially in Harlem. Spanish is the primary language spoken by a number of our patients and a large number of our staff. And using the plain language terminology, we can just straight across translate. So if we need to present these alerts in a different language, we can just straight across translate word for word, phrase for phrase in an appropriate way, and we can get the message out. And if we had to do an overhead page where we really needed to give instructions, and I'll give you an example in a second, to everybody in the hospital, we would automatically do it in both English and Spanish. And then the expectation is that our language interpreters, our nurses, would help translate it into the, 300 other languages that exist, that there could be a patient in the hospital. So I'm going to give you an example. In December of 2020, we have a large cathedral, the world's largest cathedral, actually, I come to find out, right next door to the hospital, St. John the Divine Cathedral. They were closed because it's COVID, but they still wanted to do something spiritual for Christmas. They have a huge staircase in front of the hospital, which is literally, if you walk outside my emergency department main doors, you cross a small side street and that's the steps. They did a musical, they spread people out, they did the social distancing, they were outside, and they did a choir musical presentation to anybody that wanted to gather on the street, which was very common in 2020 in New York City. Is just all of these pop-up things that we tried to do our best to social distance to get people to come together. And it was Christmas time, and unfortunately an active shooter came to the site, started firing his weapon, and was eventually shot and killed. Thankfully, nobody else was injured. He was eventually shot and killed on the steps of the church. So it was a very tragic situation for our hospital, 10 steps outside our emergency department door. Within 45 seconds of somebody, we have a paid duty police officer in the entrance of our emergency department, he noticed, he screamed out lockdown as he was running out of the building to go and take care of the situation at the church. the nurse that was standing there and the security officer, the triage nurse and the security officer immediately called, and within 45 seconds of that officer calling out, we were able to do an overhead page in the emergency department, specifically that said security alert, armed intruder in the vicinity, shelter in place. And that's all that was said. That was picked up by our, so the emergency department did a shelter in place. All of our other doors are a block away on the other side of the building. So it's a staged process, right? The emergency department did it overhead. That was picked up by telecom, and within 3 minutes of the start of the incident, it went over wide in our overhead pages. So we were able to communicate that extremely effectively and extremely efficiently. We were able to perform a shelter in place to keep our staff, our patients, everybody else safe. And our patients were noticing these things to be able to say, you know, shelter in place, I know what that means. Where can I go to be safe? And they were asking the questions. So that's kind of how it all works with plain language. I was very blessed to walk into a hospital that had plain language in the middle of a crisis, and I firmly stand with Grayson that this is the way it has to happen. So there were a couple questions here. Oh, where would we place cyber? Cyber becomes a facility alert, because if I have to do an overhead page for a cyber incident, it has something to do, well, that's not true. The only ones I've ever seen have had something to do with the facility specifically. The only other ones that we've had would be a medical alert, and it would be, how it would read would be medical alert, hospital-wide, please go to your downtime procedures. And that would be because of a failure of Epic or Eagle or one of our you know, patient reporting systems that we have. That would be a medical alert, and it would be the instructions would be go to your downtime procedures. So that's a great question. But if I can, sorry, Grace. I was going to say,
if I can add on to that, I think we're merging a lot of stuff here, you know, codes into public alerting, into planning and whatnot, and that's because it has been merged. But I think it's important to kind of recognize there's a big difference between an alert, which you know, at least in Alberta, we define as like an imminent threat to public safety, which involves the hazard, the protective action, and then where to go to find out more, and then a notification. You know, maybe you're envisioning something different, but a cyber incident or an IT outage or whatnot, that doesn't quite hit the threshold for public safety for me. Very important to notify and activate responses and whatnot, but not necessarily something that needs to go out to all of the public because it does not impact public safety. If we need to do an announcement that says, sorry, our systems are down, it's going to be a little bit of a wait, then sure. But I wouldn't say that hits alert status for me.
Yeah, so we've had two. So downtime is always an overhead page because it has immediate clinical implications. So, and yeah, somebody else said it would be a security alert. And the cool thing about that is it doesn't matter if it comes out, what kind of alert it comes out as. It's the instruction and the notification that's really important. The other one that we had that was a cyber was, it didn't turn out to be a cyber attack, but there was an issue where a bunch of our facilities equipment froze from an electronic perspective. And so that went out as a facility alerts. I can't remember how they worded it now, but it was shut down, critical systems shut down, facility alert, critical systems shut down, stand by for further announcements. And then we were actually able to reverse it before we had to make any other announcements. So I have one more quick question from Moira, and this is a really good question. How does the existing technology, specifically the panic buttons, integrate into the new approach? I'm going to tell you, I am anti-panic buttons, and I'll tell you why really quickly, but this is a whole nother conversation that we can have. When you press a panic button as one-way communication, there is an expectation that you are going to get an immediate response. And if it's something like an active intruder, for example, if I have an armed intruder come into a unit and I press the panic button, you are not going to get an immediate response by unarmed security officers. A security guard is trained to attempt to follow the movements of an armed intruder and to make sure to relay that information to the very armed police officers who will hopefully be at your facility soon. But we don't put their lives at risk. But when I press the panic button, I expect somebody to show up. And that creates a lot of conflict and a lot of issues, and a lot of concern. So I'm not a big fan of panic buttons as one-way communication tools. I understand that they're used a lot. But yeah, and there's just a lot more conversation to be had there. Our code buttons, so if I press a cardiac arrest button, or if I pull the alarm button, or in some of our cases, we use some GE equipment that has a dial on it that I can press or whatever. If it's a cardiac arrest notification, that triggers to our telecom, who would put out the medical alert rapid response team notification. So from the clinical perspective, yes, we have those. It's only for cardiac arrest. Everything else, we would actually have to make the notification. How long did the conversion take? So my understanding was the conversion from conception to full implementation was a year. I think you can concentrate that down, especially now that there's a number of hospitals, there's a number of blueprints for doing it. I think Ben and the team back in 2018, 2019, I think they didn't have a blueprint to work with, and it was a lot of shooting in the dark and a lot of practice and a lot of testing. And I think we don't have to do a lot of that testing. We don't have to do that anymore, because hundreds and hundreds of hospitals have gone to plain language. We can just borrow from them and get the right things done. So yeah, and you know, the conversation about, is it a medical alert, is it a security alert, is it a facility alert, when you go through the process of creating the templates, you kind of have the opportunity in blue skies to argue that. But at the end of the day, we have mistaken ones all the time. Like, for example, our infant abduction is a security alert. 9 times out of 10, it's actually reported as a facility alert, mistakenly, because it requires us to lock down the facility to an extent to try to prevent the abductor from actually being able to exit the building with the infant. But that's also a great example of why it's so important. Our infant abduction, when we announced the infant abduction, we announced security alert, missing child or missing infant, last seen, ACC building, clinic 260, child was wearing, and it'll give a brief description of the child. Please be on the lookout and call 4444, which is our emergency number, if you see anything suspicious. And then we have extra people in security answering the phones for every child. Now, we don't have a pediatrics unit, so if I call a missing child, it's probably the only child in the building because it's a guest of a patient or a visitor to a patient.
Jen.
Sorry
to interrupt you. We're 5 minutes over our time.
Oh, gosh.
So I just, Grayson, did you want to?
Sure, I'll quickly buzz through the responses. I think it was so interesting. But basically, we've got people from all over doing all sorts of things. We have healthcare systems which have placed their emergency management program in all different places, which is kind of interesting. And they're working with in different ways within healthcare systems based on different standards, which is not surprising, but interesting to see such a disparity here. And then with the emergency response codes, we're kind of all over the place as well. All healthcare systems on the line use emergency response codes, but it's very different as to what we use. And when I asked what code gray meant, there were about 20 different responses just within Canada, which I found really, really interesting. The emergency response code use findings, you know, do you use numeric codes? Yes and no. It sounds like most people don't. Do you use phrases like Dr. Strong or Dr. White or whatever? Most people said no, but there's still a few out there. And then in terms of public alerting, there is nothing written into about half of respondents' plans saying that we actually have to alert staff, which is very concerning to me. somewhere around half of the organizations represented here use mass notification systems. So we're all still jumping on that bandwagon. And then it was a bit of a scattered approach as to whether or not you agreed with the statement that everyone would be able to know what was going on if an emergency alert went out in your facility. And I will say here, unless you are putting out alerts in different languages in different ways, then no, not everyone's getting your alert. So I don't know if we'll ever get 100%, but I think we can be way more equitable. For the transition to plain language, and this was the real clincher here, there are some organizations who have already transitioned to plain language. There's one at least who is in the process. Most have an intent but haven't started, and then the remainder, or some have the intent but haven't started, but most haven't even considered it. And then I think we have either won over, or people already came to the conclusion that plain language is the way to go, 21-4 in this room, which means that the willingness is there, the time is now, and we should just go for it.
Awesome.
Thanks very much, guys.
Thank you very much again for the great discussion.